I'm trying today to speak about the aesthetic zone. I'm speaking on behalf of all these guys, fantastic group. We have a Korean Eureka R2 team and international team. I'm the one from North Africa. So we are sharing the same philosophy. We are trying to design therapies that they are simple and efficient for our patients. We try to figure out how to be predictable each time with the minimum invasive philosophy kept in our minds. So we are trying to design the clinical protocols to go faster, easier, and smarter. I am focused and passionate about aesthetics and the management of the frontal zone because it's very important with the eyes of the patient to get very nice facial aesthetics. We are trying to follow the current trends in cosmetic dentistry. We are trying to involve more digital technology. We are trying to understand better the biological parameters. And we are also confronted to highly demanded aesthetic patients nowadays. So aesthetic perfection nowadays, it's not a choice, it's an obligation. We need to have a perfect final outcome of the cases that we are trying. And I learned from Atlanta team too that to get very nice face, we need to have an equilibrium between the eyes and the lips. And it's like an equilibrium between different compounds of the smile, the lip, the soft tissues, the pink part of the restorations, and also the white part. The white part of the restoration, it's we need just to find a very brilliant lab pros like our colleague over there. So it's very interesting to focus on the transition zone between the white and the pink because many of the patients are showing the tip of the papillas when they are smiling. And it's all about controlling the interfaces, and we are focusing into this interface between the pink and the white. And before starting treating any aesthetic cases, we need just to keep in mind this aesthetic checklist. And the lab technician must know it perfectly to be able to restore and to manage the restorative part of the treatment plan. So there's different points that we need to focus on them to get very nice final aesthetic outcome. So the question of the day is how to achieve a high predictable outcome in implantology. It's no more questionable today that implants are working and working very, very good. We have very nice results at long term since 20 years or more. But getting this kind of biofunctional integration of the implant retaining crown is not easy, especially in the aesthetic zone. And there is nowadays, we are fortunate to work in an era that there is a code, there is a roadmap that we need to follow step by step to get the perfect final results. So let's start by the first point. Everything is facially driven nowadays. Everybody is talking about the dentofacial aesthetic parameters and analysis before starting placing implants in the aesthetic zone. We need to analyze the lip in motion and while the patient is speaking and smiling. We need to figure out what is happening in the B zone, which is the hard and soft tissue and implant surgical zone. We need to analyze also the restorative zone and what the patient is showing while smiling. So the white and pink aesthetics in the anterior region represent the most critical area from an aesthetic point of view. We are also fortunate to work in an era where the digital, we are living in a digital revolution, really, and it's a combination between the machine and the human eye. It's like art. It's almost the same what is happening in our daily life, like instead to catch a cab, we are just using apps like Uber. We are no more storing in hard disks. There is a cloud storage. We are no more sending courier just bytes. So we are living in a digital era. And the visual and digital communication with the patient and inside the team is very important. And before starting any aesthetic case, in the first appointment, we try to figure out what is happening with the visual exam share side. We have a digital photography protocol that we learned from Christian Koschmann. We ask for the CBCT, and we import everything into our Keynote file or PowerPoint if you are using Windows. And so we are collecting the data inside a digital file. So each patient coming into my clinic has a digital file where we have the whole story inside it. Sometimes people are coming just for consultation, and then they go back after a few months to get some cash, and then they come back. So when you just open the file, you will get your memory reactivated, and you will not spend time to make the diagnosis and to treatment plan the case again. So it's true you will lose a small amount of time, but it will be helpful even to show your treatment planning, the virtual one, to your patient for case acceptance. And we can share this digital file via internet, so all the team is updated, and we can even write some comments on the slides. Always after that, when we started the surgical phase in the aesthetic zone, we go through provisional restoration as a test drive, then we finalize the case. This is always my workflow in the daily basis. So starting always by a clinical analysis, photo analysis. We can just use our smartphones to catch a video of the face of the patient. We can analyze and draw some lines, and we draw guidelines. So there is three types of files that changed completely the workflow into our clinic. The first one, the videos and the photos, the JPEG file, then the Conbeam CT with the DICOM files, and then the intraoral scanners with a format like an STL file. So by being able nowadays to select the right machines and the right materials, and just reading the papers coming from Atlanta team, you can be a successful dentist. That's it. So the difference between clinicians is how they are sticking to the protocol, to the rule or not. It's true, right? This is the only difference, I think. If we select the right tools, the right machines, and perform the right protocols, we can get very nice end-up of the cases. And implants are just additional tools in our armamentarium. That's it. We have new toys in our clinics, like the CBCT machines, the digital impressions tools. We have small 3D printing, and also we can have an in-house milling. And Patel showed us how fast he's going with the CEREC machine to deliver an immediate crown. In the lab, there is also very cool tools, I think, like the in-lab scanning, the big 3D printing, and the D3 milling machine. So what we can have from this technology in the office, we can even treatment plan the case before starting placing the implant and enhancing the transition zone by adding bone, for example, or making some soft tissue management. We can treatment plan perfectly on the software interface. We can plan and fabricate a 3D printed stand, share side. And in the lab, we can get some digital models. We can even nowadays get 3D printed dentures, customized abutments, crowns, and bridges. So the workflow is shortened. We cut many errors. So we are going very accurate nowadays. Before starting placing implants, please, for the ones they want to start doing implants in the aesthetic zone, you need to master soft tissue management. If you don't know how to do it, go for courses to learn how to manage soft tissue. Like in these cases, we can just turn failure into a success by removing the ugly bridge, and by harvesting a connective tissue graft from the palate, we can just enhance the biotype on the pontic area. And I learned this technique from the papers of David Garber, so written a long time ago. By using this soft tissue technique and by reshaping the ovoid pontic, we can just have this kind of nice prosthetics with ovoid intramucosal contact of the ovoid pontic, and we can even have such nice emergence profile even in the pontic area. So we can change this failure into success just by replacing the prosthetics and just with adding a connective tissue graft. Coming to the implant field, we need to know these aesthetic implant rules. It's very easy. We need to think pink and to talk soft tissue language. That's it. And what is the ultimate goal of our therapies in the aesthetic zone? We need to have just a thick, very thick barrier, soft tissue barrier to protect the implant color to have such nice emergence profile. When we introduce a probe into the peri-implant sulcus, we don't have to see it because the soft tissue must be very thick and stable. And we can have very nice emergence profiles. Without doing a perio and soft tissue management, we can get such a nice emergence profile because beauty is just a question about lines. From a biological point of view, we know from many papers, especially from the Salama group, that we need to have a thick soft tissue, minimum thickness 2 millimeters. And coming to the bone, we need to have from 2 to 4 millimeters, ideally to protect the implant inside the bone housing. And there is an algorithm that we should know combining the papilla rules, also the attached gingiva, and when we respect the rules, we can have a very nice stability of the bone because the soft tissue will protect the bone. And we know it from many papers. It's not true only in the aesthetic zone, but this is the kind of pictures that I need to see before delivering out my final pros. I need to see very thick soft tissue around my implant neck with a nice band of attached gingiva. If not, I will try to enhance it before delivering the final pros. And if you do this carefully, you will always have this predictability and these nice emergence profiles even in the posterior zone. How nice is that? So by managing also the ovoid pontic, even in the posterior zone, we can get this regeneration of the papilla. How nice to have it between an implant-supported crown and an ovoid pontic. We need also, once we get this soft tissue management results, to design two things, to design the customized abutments and also to customize the final ceramic crowns. Because the soft tissues are not, they don't have the same height comparing to one to each other, even they are placed in the same patient. So we need to design this kind of customized abutments to situate nicely the finishing line, even for cement retained crowns, because the excess of the cement is very dangerous for the final outcome, and it can peri-implantitis can happen. So by respecting the rules of the soft tissue architecture, we can get very nice emergence profile even in the posterior area, and we can get very stable results over time. So you can see how nice it is. From an interdisciplinary mind, like I learned from the steps showed by Henry yesterday, we always start by analyzing the cases. We analyze the space, the occlusion, the tooth proportion, before going to place the implants, where is the restorative zone is ending, and where to figure out where to place the implant according to the crystal bone of the adjacent teeth. So we need to get this kind of pictures so we are sure that the proportion of the final crown will be perfectly matched with the adjacent teeth. And then once we get this kind of results, it's easy to design the final ceramic crown, a screw-retained one to avoid the cement excess inside the sulcus, and we can go through a screw-retained monolithic zirconia crown with such kind of final result. The message for me is you need to focus on each step because it's very important to know the details. And when you know the details, you can just pay attention to them and you can get very nice results immediately, and it will be stable over the time. If you don't have these conditions, you don't have enough bone and enough soft tissue thickness, just try to build it everything from zero. So you need to build first the bone to get very nice thickness of the buccal plate from the labial part of the extraction socket, and then we will just enhance the soft tissues. If you are dealing with posterior zone, just add some bone in the vertical dimension to be able to place implants. So it's advanced bone management, but we need to understand how it works to have this kind of bone augmentation to be able to place the implants in the ideal position, and then once the implant is placed, just manage the soft tissue by free gingival grafts, connective tissue grafts. Just do whatever you want to have at the end of the day, very thick bone and very thick soft tissues around the implant. And then we are coming to the restorative management. And by using a digital technology, we are able to perform such kind of crowns and veneers, but we still need the artistic work of the ceramist to design perfectly the details of the anterior architecture and to be able to deliver such kind of beautiful implant retained prosthodontics. So let me share with you this classification. It's a very useful one. It's amazing. Once the patient is coming in and he's sitting, I just figure out which extraction site I have to deal with. If it is an ideal site, I try to preserve what I have. If I have a labial deficiency, I will try to build up the bone again and the soft tissue if needed. And for extreme type 3 extraction sites where we have interproximal and vertical defect, I learned from Maurice you don't have to extract these roots or teeth before trying to extrude them to be able to regenerate the soft tissues. If not, it will be a nightmare and it will be a very long process to rebuild everything. So this is the philosophy of Atlanta team. It's very nice. It's very simple. If you are dealing with cases in the aesthetic zone, you just identify the aesthetic risk factors and then design a therapy that will preserve or develop type 1 extraction sites and integrate all of the story into your treatment planning. Like in this case, a young lady coming to my clinic for a hopeless center incisor. Okay, actually it's a type 3 site because we have a small loss of the central papilla. So first thing, you have to gently extract the root. It's a broken tooth. So by using peritomes and atraumatic forceps, once you extract it, even when we have such a periapical granuloma, we need to take care about cleaning the extraction socket. First thing, this is I learned from Andre Sadoun, you need to do the bone mapping if you are going freehand surgery. So where is the bone comparing the free gingival margins? And then you analyze your walls. If you have an intact walls, you can go for immediate implant placement. And if your implant is very stable, you can do immediate temporization. So before starting the drilling process, we need to clean the extraction socket using this mini Lucas curettes. You can go to the apical part of your extraction socket and then clean it. And then easy, you can just drill using the drilling protocol of your implant system, and you can just take time. Take time in each drill. So you need to figure out how to place ideally the 3D in ideal 3D positioning your fixture. So take your time. Place the first drill and then take a picture. If it's perfect, then go to the other drill. If it is not perfect, just go back and do it again. And we are trying to place the implants toward the palatal wall. we calculate immediately the final insertion torque and the ISQ values, and if we have more than 45 Newton centimeter of insertion torque and more than 75 ISQ for single crowns, we can predictably place an immediate crown. We graph the gap, and also I try to boost the biotype by placing connective tissue graft in the labial part of the extraction socket to respect the rules of the dual zone. It's very nice to know. Look how many details that can influence your final outcome, even in the bone zone or the transmucosal zone. So it's very important to know these details to be able to figure out how to perform the right procedure. And from Uli Grander's paper, he showed us that if you are dealing with extraction and immediate implant placement, it's better to put the potential into your hands and make a connective tissue graft. We are not losing rich volume by adding connective tissue grafting. In many cases, we are gaining soft tissue thickness and even the bone. So by using these microblades, we can just desiccate a partial thickness pouch into the buccal area, and we insert this connective tissue grafting harvested with just one line. So it's a very minimum invasive, and I'm doing it for free for my patients. Just enjoying harvesting this steak from the palate. So it takes just 2 minutes to harvest and like 10 minutes to suture it, but it's very beneficial for the patients. And immediately after, once we secure the bone graft inside the gap and added the soft tissue into the labial part, we deliver immediate temporary crown by using a very nice temporary abutment called fuse abutment that can break if we have an overload of the temporary crown. So the implant will be stable inside the extraction socket, and if the patient is trying to bite with a strong force, just the fuse abutment will break without taking the risk of the implant to do micro motions. So there's a different angulation, different designs for the fuse abutment, and we can get this nice S-line inside the transmucosal zone. So we deliver immediately a screw retained one piece at the crown. We try to support the papillas, and we leave some concavity in the labial part to leave more space for the connective tissue to grow in. So the use of the temporary crown, the aesthetic zone, is very important because it will protect your extraction site, what you placed inside it, like the bone and connective tissue. It will shape the ideal emergence profile, and you can use it to capture the ideal soft tissue management that you have done. And we need just to wait, and we need just to wait for minimum 6 months. And one of our colleagues, Davide Foronato, is waiting for until 9 months. He's just saying you need to just wait to the soft tissue to express themselves. Just wait. Sometimes you are in a hurry to deliver the final crown, but when you are dealing with the aesthetic zone, just wait, and you will get this nice emergence profile with the very nice thickness of the labial, soft and hard tissues. And which kind of abutment we need to use? If you have such thick, soft tissues, it doesn't matter if you are using a titanium abutment or a ceramic abutment. And from the paper of Zhang, it's very nicely described. So we deliver just a cement retain PFM crown, and it's not that expensive for my patient, and we can get very nice results even with the PFM. I want to share with you, it's a complex case that summarizes all the techniques that we are using to manage the full mouth rehabilitation. A patient come in with this situation, a very low lip line, hopefully. When we take the intraoral pictures, you can see that he is suffering from a periodontal disease. The bridges are moving, and so we tried to figure out what we can do. He's living outside the country, overseas. and we can see a very dangerous periodontal disease in the frontal zone. This is the maxillary posterior areas and the mandibular ones. So I'm always starting by doing the easy surgery first for the patient. So we are doing the mandibular surgery first, and then we go forward to the upper arch. So you can see from occlusal point of view that we have actually nice width of the residual ridges. My treatment plan for the complete full mouth rehabilitation will be this. I'm trying to place 10 implants. So I'm going single for the second molars. I'm doing a bridge, if I can, from first premolar to the first molar. The canine is very important to have an implant on the canine because it will hold the occlusion, the dynamics of the occlusion, and in the anterior zone, 4 units bridge. In the mandibular area, I will try to place single implants. And we started by extracting the roots for the molars. And the most important thing when you are doing the atraumatic extraction is to separate the roots to try to keep the septal bone. And then we place the implants. We elevate a small flap, so I have to control the ideal depth of the implant neck because it's a freehand implant placement. And then we just graft the gaps and place this huge healing abutment. By using this 10 millimeter healing abutment, I'm not currently advancing my flaps. So I will keep the tissue where they should be, and it will secure my extraction socket. In the left side, we just place the implants, and we pay attention to the space between the implants for premolars and molars. And we figure out how to start shaping the emergence profile for the molar by placing wider healing abutment comparing to the premolar zone. Once the implant placed, we keep the patient in the room. He rests a little bit, and then we go for the upper surgery. We started by the right quadrant by placing the implants in the premolar and then the 2 molars. For the left side, we need to extract the roots and try to clean the granulation tissue before starting drilling and placing the implants with nice deep threads that can get for us a nice primary stability even in the weak bone in the molar extraction sites. And we try to place the implants between the roots. And after that, this is the gap that you are talking about, Joseph. It's here. So even the implant neck is far from the buccal bone. And we place the healing abutments, and the nightmare was to manage the anterior zone. So we extract the root, we elevate the flap, and you can see a huge destruction of the buccal areas of the frontal tooth. So I'm trying to place just the implants, ideally comparing to the bone level of the adjacent tooth. I will keep it so I can control the implant axis. I place the implants where it should be. I add some bone grafts, and this is a very nice tool with the iGen that will stabilize the blood, the clot, and also the bone particles inside the volume that you want to add. We need just to add the pericardium or collagenous membrane for cell selection. And over that, we place a connective tissue graft to be sure that we will not have any perforations in the aesthetic zone. You can see here the implant is placed a little bit deep in the palatal wall, but it was exposed. And by placing the bone particles and the iGen, the membrane, the connective tissue graft, we can just ideally 3D placing the implants. And the maxillary surgery was done in one shot. We let it heal a little bit. 4 months later, look how nice the soft tissue result for immediate extraction socket. We have very nice width. We have very nice attached gingiva, especially in the lower mandibular areas. Look here, the fresh extraction socket management with the immediate implant placement, how thick the soft tissue were, just by selecting the right healing abutments. For complete for full mouth rehabilitation, we are always do a temporary rehabilitation, PMMA, CAD/CAM realize. So we are able to test drive the occlusion, the aesthetics, and once we have all the parameters controlled, we go for the final rehabilitation, and we are using the PMMA crowns to mount the case into the articulator, so it's very accurate to select the right occlusion paths and all the story behind the complete rehabilitation. 4 months later, we remove the whole thing, and you can see how nice the rehabilitation of the lower arch. The patient will go for 4 months, and he came back. You can see the ovoid pontic are already designed. The occlusion is quite good, and we just remove the whole thing. We scan the upper and lower arch, and then we make a cross mounting. We will start just to scan the temporary, so the lab will be able to design the customized abutments and the crowns according to the prosthetic corridor that we selected with the temporary phase. Once we have the prosthetic corridor, we design the customized abutment to support the zirconia, so we don't have any shipment. So it's very important to support your zirconia framework or your layered ceramic by using this customized abutment, and we can, using the details of the CAD/CAM, the software, we can just locate ideally the margins of the finishing lines, not that deep inside the peri-implant sulcus. So we will go cement retained in the upper arch and screw retained in the lower one. So you can see the design and the manufacturing of the customized titanium abutments in the posterior area, and the hybrid zirconia ones for aesthetic reasons in the anterior zone. Then the lab will just mount the ceramics, so he can keep the speak curve and all the details that we want to deliver at the final outcome. He starts mounting the ceramics, and then once we mounted the upper arch, we go for the upper one. And this is the final ceramic work, which is actually not bad for Tunisia. I suffered a lot to get this kind of results, very nicely, lab technician and very fine work. This is the delivery session. You can see the ovoid pontic, always the same shape of the soft tissues, architecture around the implants, and we place, look at the center papilla, it's very nice. And we deliver the final customized zirconia abutments here, and the one-piece titanium abutments in the posterior area. And the final result was actually very good. I'm happy with this case. This is the day of delivery. We are pushing the tissues so we can have very nice papillas coming down, and you can see the emergence profile in the posterior areas. I have the follow-up, 2 years follow-up of the case, and you can see we have very stable level of the bone, but also the soft tissues, because the design of the therapy of the bone manipulation and also the soft tissue were well thought. With this case, I want to finish my lecture. Thank you.